Welcome back to our coagulation unit. In our previous lecture, we discussed kind of an overview of what coagulation entailed. We had our primary phase, we had our secondary hemostasis, and then our fibrinolytic system. Today, we're going to be a little bit more specific about where things can go wrong. So I really kind of want to introduce you to some of our coagulation disorders. Now, keep in mind, at this point in our course, you will need to begin memorizing your COAG cascade. I recommend that you draw it out and know each step so that you can really familiarize yourself with what exactly is happening when we talk about these different things. In addition to that, it will be very helpful for you to know your COAG cascade, be able to draw it out and diagram it as a study aid and also as an aid for you during your exams. I do allow you to draw that out freehand as a guide for yourself, but from memory on your scratch paper when you have scratch paper for your exam. So let's take a step back and come back to our coagulation factors. As you know, we have specific proteins involved in hemostasis. These proteins circulate as inactive precursors, and in their precursor state, we call them zymogens. Zymogens are then converted to an active form via an enzymatic reaction, and the active form then participates in the coagulation cascade, leading to the formation of thrombin. Thrombin is going to be a very big player in coagulation because not only does it play a role in the formation of fibrin, but it also has a role in activating platelets in our primary phase of hemostasis and activating something that we'll learn more about later on called protein C, which is part of our fibrinolytic system. So thrombin is important because it aids in all three phases of coagulation. All right, so let's talk a little bit about some of those causes of impaired coagulation. Impaired coagulation normally falls under two kind of broad categories. First, we have our quantitative causes, and then we have our qualitative causes. Our quantitative causes are related to the amount of COAG factors or components available for use when in need. The first quantitative impairment is a decreased synthesis of our coagulation factors. This is considered to be a true deficiency, and it is caused by a genetic defect or a defective gene, some type of inherited pattern from one's parents. The second is loss or consumption of those factors. For example, if we have a patient who has a motor vehicle accident with a large amount of blood loss, along with the spilling of that blood goes their coagulation factors along with it. Because remember, the circulation of those coagulation factors are always present. It's just they haven't been activated yet. And if they spill out with a hemorrhage, they aren't there in the body to become activated the way they should be to stop the bleeding. The other type of quantitative coagulation impairment is due to DIC, that disseminated intravascular coagulation. And we have talked about DIC a few times. If you think back to our white blood cell unit, when we talked about our AMLs, we did discuss that I believe AML M3 and M5 are highly associated with occurrences of DIC. And that's because some of the characteristics of those disorders or of those acute myelogenous leukemias, they accidentally activate the coagulation cascade without reason, and then it becomes a dissemination. With that dissemination, small clots are going to form throughout the body, and as those clots are formed, that clotting utilizes up all of the platelets, all of these circulating coag factors, and ultimately leads to the consumption. So now, when the time arises and they actually need to have those clotting factors available for normal reasons or for appropriate reasons, now those factors appear to be deficient. So this is kind of a secondary quantitative cause, not genetic. The second category is qualitative, and this is going to be where we have synthesis of abnormal or dysfunctional coagulation factors, and something where a defective gene causes the molecule structure to be abnormal. And remember, the COAG cascade is based on enzymatic activity and reactions. If the enzyme and substrate don't meet and match the way that they should because of an abnormal shape, coagulation can be impaired. We also have inappropriate inactivation of the factors by inhibitors or by immune factors like antibodies. And we'll talk about some very specific conditions, both quantitatively and qualitatively, as we move forward. So there are a few different types of occurrences of coagulation disorders. One, obviously, we've got inherited or acquired. The frequency can range from extremely rare to relatively common. Clinical symptoms may range from mild to life-threatening, and some are even asymptomatic until the point of no return, where we are in desperate need of coagulation. Acquired disorders are seen more frequently in clinical practice than hereditary disorders. So keeping that in mind, let's talk about some of those acquired disorders. Acquired disorders of coagulation are usually associated with multiple factor deficiencies, and that could include vitamin K deficiency. So if you remember, we talked about the vitamin K dependent factors, so factor 2, 7, 9, and 10. Those are going to become decreased if we have a vitamin K deficiency. If we have liver disease, because remember, the liver is where those vitamin K dependent factors are produced. Hemorrhage, so hemorrhage is acquired, so we're losing those coag factors as we lose our blood. Those consumptive coagulopathies like DIC. Another acquired cause for anticoagulation or for coagulation disorders is induction onto anticoagulant therapy. I mean, that one wouldn't really be acquired by mistake, but we definitely would consider that to be a disorder if we're looking at normal versus abnormal. This is just done for therapeutic reasons based on patient's need and history, etc. And then treatment with various drugs. What would make one suspect that they or their loved one has a coagulation disorder or clotting disorder? Well, here are some of the clinical manifestations. And when I say clinical manifestations, I'm talking about the things that we can see, and so signs and symptoms, things that we would go to the doctor for, or that a patient may go to the doctor for because it's not really normal. First one is going to be deep tissue bleeding with hemarthrosis. So we'll see some bleeding into the joints. Deep intramuscular bleeding. Maybe spontaneous life-threatening intracranial bleeding. Moderate to severe mucosal membrane bleeding, like GI bleeding, genitourinary bleeding, menorrhagia or heavy and prolonged menstrual bleeding. Intrapulmonary bleeding, so coughing up blood. and epistaxis, which are nosebleeds. Ecchymosis is another term that we can use for bruising. Some patients will also develop pinpoint bruises called petechiae. However, patients do not develop petechiae or purpura except for in von Willebrand's disease and a couple of other vascular disorders. They are generally not found in coagulation protein defects, but von Willebrand's and TTP are two of the exceptions, and ITP, which we will talk about later on. Let's talk about laboratory evaluation methods that we might use to help us discover or confirm or rule out a coagulation disorder. Most of the clinically significant coagulation factor disorders can be detected by prolongation of coagulation testing. And this is going to depend upon the conversion of fibrinogen to fibrin. Remember, thrombin acts upon that for an endpoint determination. And at least one or more of those screening tests will be abnormal. So these are our basic kind of screening tests. Our pro time, and if you remember, our pro time is going to measure the factors in the extrinsic pathway and the common pathway. The PTT is going to measure the factors that are present in the intrinsic pathway and the common pathway, fibrinogen, and thrombin time. So a definitive diagnosis is dependent on a specific quantitative factor assay. That means if we have a prolongation in any one of our tests, we have to go and now determine, okay, for example, let's say we have a pro time prolongation. We need to look to see, okay, is this a factor 7 deficiency or a PTT prolongation? Is this a factor 8 or a factor 9 deficiency? And we will have to go in and do a factor assay that is specific for that or for those particular factors to determine whether or not there's a deficiency in any one of those. If there is found to be a deficiency, we have a couple of treatment options. So replacement therapy is the method of choice. We have a few options for kind of like a broad spectrum administration and then some that are more specific. So let's talk about one of the more broad. So FFP, fresh frozen plasma. This is going to contain all of the factors. And this is what we give to patients when they are losing their coag factors fast because of hemorrhage or massive trauma, because we can give them all at once, quickly, and hopefully it will help them stabilize after hemorrhage. The one thing about this is we may have a little bit of a decrease in factor 5 and 8 because they are both heat labile, which means that they're a little bit unstable in heat. And of course, if you know anything about frozen plasma, you know you have to defrost it in that water bath. And so sometimes factor 5 and 8 don't really care to go through that process. Another option that we could use for some disorders is cryoprecipitate. This is going to contain von Willebrand factor, fibrinogen, factor 8, and factor 13. So if we have any of those deficiencies, cryoprecipitate might be a better choice to give simply because FFP is expensive, although cryoprecipitate is also expensive, but we would save that. We would want to use the most specific type of treatment, and cryoprecipitate would be more specific than FFP. All right, prothrombin complex contain factors 2, 7, 9, and 10. We know that those are vitamin K dependent, and there are prothrombin group factors, and hence the name prothrombin complex. Novo 7 is going to be a very specific concentrate for replacing deficient factor 7 in the extrinsic pathway. So if we were to have a prolonged PT and a normal PTT, then we might be looking at a factor 7 deficiency, and that patient would be given Novo 7. Factor 8, also known as hemophilia A, is those patients are given recombinate, which is just factor 8 concentrate, and then Benefix, which is factor 9 concentrate. Remember, factor 9 is hemophilia B or Christmas disease. It ends in IX, which is the same as the Roman numeral IX for 9. So that's how I remember it. Recombinate ends in 8, which is factor 8. And Benefix is 9, which Roman numerals are IX. And then the last one is Humate, which is just von Willebrand factor. I promised you we would speak more in depth or more thoroughly about our factors, so let's begin. Factor 1, also known as fibrinogen, is soluble in its zymogen form. Once thrombin has acted upon it, the fibrin clot becomes insoluble with the help of factor 13. It is the most abundant coagulation factor in the circulation of normal adults. It is synthesized in the liver, and it's contained in the platelet alpha granules. So think about that. It's not only in the coag cascade, it's also inside the platelets. There are congenital deficiencies, but they're relatively rare. And those that are inherited are usually autosomal recessive in afibrinogenemia or hypofibrinogenemia, and then autosomal dominant in dysfibrinogenemia. Now, we're going to talk about those in just a minute so we can break them down further. But first, let's talk about the normal range of fibrinogen. We should have 20 to 400 milligrams per deciliter of fibrinogen in circulation. However, our body is, once again, I will say it over and over again, amazing at compensating, and hemostasis can be achieved with levels of only 60 to 80 milligrams per deciliter without risk of hemorrhage. So these inheritable types of fibrinogen deficiencies are really three. First, we have afibrinogenemia, which is homozygous with no detectable fibrinogen. So these people cannot clot. It is a more severe disease at birth, so the umbilical cord and mucosal bleeding, baby may have intracranial hemorrhage, but they generally have a milder course than severe hemophiliacs. Hypofibrinogenemia is usually a pattern of inheritance that is heterozygous, so you have some normal fibrinogen and the other half of your fibrinogen is abnormal or missing. Plasma levels are usually 2 to 100 milligrams per deciliter for patients with hypofibrinogenemia. Usually there aren't very many bleeding symptoms because, again, we only need a smaller amount than usual for proper clotting, and it's an autosomal recessive inheritance. Now, those are both quantitative. Let's talk about our qualitative fibrinogen deficiency or disorder. Dysfibrinogenemia is an autosomal dominant inheritance pattern, and these patients may be homozygous or heterozygous. Most patients have no symptoms or clinical manifestations, and those with symptoms are usually only have mild bleeding with trauma. However, some patients have thrombotic disease, so it's going the other way. Our laboratory testing is going to really be beneficial and helpful to us to identify the type of deficiency that we have. With a patient who has afibrinogenemia, the pro time, PTT, thrombin time will be infinitely prolonged. That means there's no clot formation that will occur, and that's because fibrinogen acts as a substrate to thrombin, and if thrombin cannot activate fibrinogen and convert it into fibrin, there will be no clot. Because remember, fibrin has to go in, form that fibrin mesh throughout the platelet clot, of a platelet plug, waiting for factor 13 to come in and stabilize it. However, if we do a mixing study, which is where we take normal pooled plasma and add it into our patient sample and then run a PT, PTT, and thrombin time. This will correct. That means we will now have normal values, and that is going to give us an indication that when adding normal pooled plasma, our results corrected and they now look more normal. So that means when we added that normal pooled plasma, we added in something that was deficient from the patient's original sample. Now the trick is we have to do a confirmation. So in order to confirm which of the deficiencies is occurring or which of the factors are deficient, we need to do antigenic and functional assays. For patients with afibrinogenemia, we are going to find less than 5 milligrams per deciliter of fibrinogen in that patient sample. We might have a prolonged bleeding time or PFA 100. We may have abnormal platelet aggregation patterns with ADP and epinephrine, so our platelet aggregation is also going to be abnormal. And then we may have a decreased platelet count. The other thing that's important is that we have other testing like our SED rate that's going to be approach 0, so keep those things in mind. Now, a patient with hypofibrinogenemia, we're going to see prolonged or variable PT and PTT. Fibrinogen is going to be lower than usual, so it won't be, our normal range, but it'll be 200 to 100. And these patients normally clot spontaneously because remember, we only need about 60 to 80 for proper clot formation. The clot retraction in these patients, however, is abnormal, and the red cell fallout is increased, meaning we're going to have an increased SED rate. The qualitative form of fibrinogen deficiency or disorder is dysfibrinogenemia. The PT and the PTT might be normal to moderately prolonged. Normally, these patients have about 100 milligrams per deciliter of fibrinogen, and that will demonstrate normal clotting results, but it really depends on their pattern of inheritance. We are going to see a prolonged thrombin time, and this is what our specific fibrinogen assay. So our test that is specific for fibrinogen is going to look like this. In a homozygote versus heterozygote, 0% is clottable with a homozygous patient, and we're going to have reduced clottability with a heterozygote. Precipitation, 100%, 100%. Immunologic, 100%, 100%. So really, the clottability is really where we're going to see the difference between the homozygous and the heterozygous patients. What if we find that we have a fibrinogen deficiency? Well, we obviously need to treat it if it's going to cause us problems or cause us to be at risk for hemorrhage. So obviously, we want to treat it when significant bleeding could occur or when surgery is planned. So we really want to mitigate any bleeding risks that might be associated with surgical procedures or injury. If you remember to the treatment or the replacement therapies that we just talked about a little while ago, cryoprecipitate is a treatment of choice, and it contains around 250 milligrams per deciliter of fibrinogen. So we would transfuse this cryoprecipitate to the patient, and this will kind of give them a running start or a head start so that if there is any bleeding, that they have all of the factors necessary to regulate it and to coagulate appropriately. Next, I'd like to talk about factor 2, otherwise known as prothrombin. Prothrombin is the precursor to thrombin, and it is converted to thrombin through the means of active factors 10, factors 5, calcium, and some phospholipid activity. It is a glycoprotein synthesized in the liver. Unfortunately, these deficiencies are extremely rare. However, we can sometimes see mutations in that prothrombin gene, which causes both quantitative and qualitative deficiencies. And it is the most abundant and has the longest half-life of all of the vitamin K dependent factors. Like all other zymogens, prothrombin has no coagulant activity until it is converted to thrombin. But thrombin is really the ultimate goal of coagulation because it plays such an important role. It converts fibrinogen into fibrin. It activates factors 8, factors 13, protein C, and it induces platelet aggregation. So thrombin really plays a significant role in all of the different stages of hemostasis. We see its activity in primary hemostasis with that induction of platelet aggregation. We see it heavily in our secondary hemostasis with the conversion of fibrinogen to fibrin, activations of factor 8 and then factor 13. And then it also plays a role in our fibrinolytic system with the activation of protein C. Now, we haven't really talked too much about fibrinolysis, but one of the important roles of protein C is that it actually helps regulate the activity of active proteins 5 and 8. And so it's kind of like putting the brakes on factors 5 and 8 so that it can't propagate the continuation of the coagulation cascade or kind of run amok, so to speak. So it's really just like puts the brakes on it. People with a prothrombin gene mutation inherit that through an autosomal recessive inheritance pattern. And there are treatments for it we're going to talk about a little bit, but let's first talk about some of the clinical manifestations. So when we're discussing clinical manifestations, really what we're saying is what are the signs and symptoms that can be presented when the patient goes to see a physician? What are they experiencing that can be observed? So some of those clinical manifestations for factor II deficiency, first of all, we see mild bleeding from those mucous membranes. So they may have a lot of bleeding from their gums when they brush their teeth. Epistaxis, so they may have nosebleeds, excessive bruising, and for females, menorrhagia or heavy menstruation is highly associated as well. If a patient were to go to their physician complaining of these clinical manifestations that we just previously talked about, it's likely that the physician would order coagulation testing for this patient to kind of see what's going on. If a patient did have a factor II deficiency, our screening tests of the PT and PTT would both be prolonged. Now, if you think about where prothrombin lies within the coagulation cascade, we know that that is associated with the common pathway, and that's why we're seeing prolongation in both the PT and the PTT. Our thrombin time testing would be normal, but when we go to do a specific factor assay for factor II, we would find that that activity would be decreased. We may have a bleeding time that is normal, and a physician may also suspect a prothrombin gene mutation, and we do perform prothrombin gene mutation testing here at St. Luke's in our molecular department. Now, the reason we do some of these tests is to be able to differentiate between a quantitative deficiency or a qualitative problem. So, did the patient inherit a true deficiency where maybe they really don't have enough or produce enough prothrombin? Is there an immunologic response? So have there been any antibodies or any immunologic inhibitors that are acting against factor II? Or has this patient inherited a prothrombin gene mutation, which is going to change the normal shape of that protein, making it dysfunctional? The good news is, or maybe the bad news, depending on how deficient the patient is that hemostasis really only requires about 30% of our normal levels of factor II. So if a patient is mildly decreased, they may not ever know that they have a factor II deficiency until a big event happens. This is why diagnosis is so important, so that we can manage the condition in the case of hemorrhage, significant hemorrhage, or planned surgical procedures. And in the case of people with factor II deficiencies, prothrombin complex or fresh frozen plasma is going to be the best choice for replacement therapy. And again, if a planned surgical procedure is in the future of this patient, physicians typically do coagulation testing prior to your surgery, and if they are found to be deficient in anything, and specifically factor II in this case, they would be given those replacement therapies to mitigate that risk of hemorrhage. Let's talk for a minute about factor V, also known as proacceleratin or parahemophilia factor. Fortunately for us, these deficiencies are extremely rare. Acquired deficiency can sometimes occur in patients with consumptive coagulopathies such as DIC, and also severe liver disease. Now, the reason why we see deficiency or acquired deficiency for factor V occur in patients with liver disease is because these factors are produced in the liver, but they're also produced in megakaryocytes. Now, if you think about megakaryocytes and their relationship or their role in production of platelets, we know platelets play a really important role in our primary hemostasis, and factor V is also found in the alpha granules of these normal platelets. We will talk more about platelet aggregation and secretion in our primary hemostasis unit, but just know that factor V isn't just in circulation, it's also within the alpha granules of normal platelets. And this is why we need platelet-poor plasma for testing, because we want to eliminate those platelet factors and just test the performance of the in vitro reagents and compared to the factors that are present in just the plasma, not in the platelets as well. So factor V is activated by thrombin. So here we go. Thrombin again is playing a really important role in activation of other factors, and in this case it is part of our secondary hemostasis. Inherited deficiencies are typically associated with autosomal recessive inheritance patterns, and there's one specific type of gene mutation that can occur called a factor V Leiden gene mutation, and we're going to talk in more depth about that as we go along. If a patient were to have a factor V deficiency, some of the clinical manifestations that we may see are moderate to severe mucosal bleeding, and this seems to be kind of a pattern. I think because it's easily observable in day-to-day activities, brushing your teeth, etc. Large subcutaneous hematoma. So these patients are going to get very, very large bruises that have some blood accumulation under the skin. Maybe spontaneous bruising following trivial injury. So you bump your leg on the table and then you have a massive bruise. It just kind of seems a little bit excessive. Menorrhagia, again, is common in factor V deficiencies. And women who are postpartum may have postpartum hemorrhage occur. Typically, patients who are heterozygous for this inheritance pattern are usually asymptomatic, and that's because they have enough factor V to carry on normal hemostasis in normal circumstances, unless there's a large event, such as a surgery or maybe pregnancy and delivery. So here are what our laboratory results would look like in a patient with a factor V deficiency. We would first do that coagulation screen. We would see a prolonged PT, a prolonged PTT, and again, factor V is associated with that common pathway, so we are going to see prolongation in both the PT and the PTT. The thrombin time will be normal, and then our factor V assay will be decreased. So one of the reasons why heterozygous patients typically are asymptomatic is because hemostasis requires only about 10 to 15% of our normal levels for factor V. So even if a patient has some deficiency, as long as they are able to maintain that 10 to 15%, they should typically be asymptomatic unless some large event happens. Fresh frozen plasma is going to be our factor of or our factor replacement of choice. Although because of that heat liability or that instability, we may see slightly decreased levels of both factor 5 and factor 8 in fresh frozen plasma. Deficiencies in factor 7, also known as proconvertin, are extremely rare. But for patients who do have deficiencies, typically they are of an autosomal recessive inheritance pattern. Both absent deficiencies and dysfunctional forms exist. Homozygous patients typically have equal to or less than 10 units per deciliter, and then heterozygous patients typically have 40 to 60. And again, these patients with the heterozygous pattern of inheritance are usually asymptomatic, and that is because, as we've talked about all throughout our hematology course, our body is amazing and compensates very well for deficiencies across the board. Now, this is a glycoprotein that's produced in the liver and vitamin K dependent. It is the factor with the shortest half-life of only 4 to 6 hours. And so patients with a deficiency who need replacement therapy have to have it more frequently administered. Patients with factor 7 deficiencies may have some of these clinical manifestations. Again, those deep muscle hematomas, epistaxis, menorrhagia, hemoarthrosis, so we may have bleeding into the joints. And patients with 5 to 10% of normal levels may have little or no bleeding. Those with 1% may have serious bleeding similar to hemophilia. So if you think about hemoarthrosis, we also see that in a lot of our hemophilia patients. And again, hemophilia A and B, so factor 8 and 9 deficiencies. But again, we only need about 5 to 10% of our normal levels to have no, a decreased incidence of bleeding. That would be under normal circumstances. However, again, if a major injury were to occur, these patients would still be at an increased risk simply because the injury would utilize up what was available, and then they would be very depleted. Laboratory testing for factor 7 deficiency would look like this. We would do our PT-PTT screen. So our PT would be prolonged, and that's because our factor 7 is associated with that extrinsic pathway. Our PTT would be normal. And we might even do something called a stipend time. And with a factor 7, a stipend time would be normal. So the way that a stipend time works is we would do a PTT and we would utilize Russell's viper venom as the thromboplastin. And then stipend time is really dependent upon factors 2, 5, and 10, platelets, and phospholipids. So if you remember, I'm not sure, I'm trying to remember if we've discussed this or not, but sometimes snake venom can be a catalyst for coagulation. And so utilizing that venom to stimulate coagulation and measure it is kind of helpful in some ways. Now, factor 7 does not affect the reaction because it isn't factor 2, 5, 10, or platelets and phospholipids. And it is really one of the ways that we can differentiate right as we're coming into that common pathway. So if you think about it, factor 7 is associated with the extrinsic pathway, but then just below, this is where it branches down, and we have factor 10, 5, and prothrombin. And then, of course, we have also platelet interactions, etc. But this can kind of help us differentiate. Are we looking at factor 7 or are we looking at something like factor 10? We would do a factor-specific assay for factor 7, and we would find that to be decreased as well. Therapy for factor 7 deficiency is going to look something like this. In the event of a large bleed, fresh frozen plasma would be a treatment of choice. If we know the patient has a factor deficiency and we're doing replacement therapy specific for factor 7, they may have injections of Novo 7. The good news is hemostasis really only requires about 5 to 10% of normal levels. But because of this frequent or this short half-life, we have to have more frequent transfusions of Novo 7 if we are just performing replacement therapy for these patients. An interesting thing about our Novo 7 concentrate, we can actually use Novo 7 to circumvent the intrinsic pathway in the event of a factor inhibitor for factor 8, so a specific factor inhibitor. And what factor inhibitors do is they actually inhibit the function or the activity of a specific factor. Usually that is in correlation with maybe someone who has hemophilia A. Now don't get confused, factor 7 is not hemophilia A, but factor 8 deficiency is, so we can give them something called recombinate, which is a specific factor replacement for factor 8. But sometimes our body or our patient's body might develop an immunologic response, and now these immunoglobulins are binding to that factor 8 recombinant and inhibiting factor 8 activity. So now we have an inhibition of factor 8, which usually is a response to that recombinate factor 8. So what we can do is we can actually give the patient factor 7, and it will circumvent the intrinsic pathway and bypass that step to allow normal coagulation to occur. And we'll talk more about factor inhibitors a little bit down the road. I just want to introduce you to that because Novo 7 is going to play an important role in our ability to circumvent that inhibitor. Speaking of factor 8 deficiency, and in this case, we're going to talk about factor 9 as well. So factors 8 and 9 deficiencies make up the largest number of those having lifelong bleeding disorders. With regard to deficiency of factor 8, we call this hemophilia A, or sometimes you may hear it referred to as hemophilia, classic hemophilia. And factor 8 deficiency occurs in about 1 out of every 10,000 males, and it is 10 times more common than factor 9 deficiency, which you may hear referred to as hemophilia B or Christmas disease. Let's talk about factor 8. So factor 8 is a glycoprotein. It's present in only trace amounts in the plasma of healthy individuals, and it is synthesized in several different sites of the body, but the liver appears to be the most important. So patients with liver disease may become or have an acquired factor 8 deficiency. And like factor 5, factor 8 is also one of our unstable factors. It is a heat labile factor. Deficiencies are usually sex-linked recessive inheritance, and an interesting fact about factor 8 is that it can also be an acute phase reactant, which means that we may see elevated levels during trauma, pregnancy, inflammation, chronic illness, and strangely enough, oral contraceptive use. Approximately 10 to 15% of hemophilia A patients will develop inhibitors, and we just talked a little bit about inhibitors, but the inhibitors that are developed are usually in response to the factor 8 recombinant therapy, and again, we can use that Novo 7 to kind of circumvent that part in the coagulation cascade so that normal coagulation can continue. Normal range for activity of factor 8 is going to be 50 to 20%. Now remember, when we're measuring factors with our factor assays, we're really looking for the amount of activity that we can measure. So we're not actually measuring the antigen per se, we are measuring the activity that we can measure that is in response to the coagulation that we stimulate in vitro on our instrument. So when you see a range, we're talking about the activity that that factor is able to produce. And another common name that you may hear factor VIII called is anti-hemophiliac factor. So that kind of tells you that hemophilia is associated with factor VIII, and specifically hemophilia A or classic hemophilia. The good news, I forgot to mention this, the good news about acute phase reactants is typically when you have an increased activity of factor VIII and it is found to be due to acute phase reactivity, it's pretty much clinically insignificant. So it's not really cause for alarm. We just have to really, if we do see an increased activity, we really have to look at the patient history, signs and symptoms to determine whether this is an acute phase reactant or if maybe there is an issue with our regulatory protein C and S, because remember protein C and S help regulate factor VIII activity. So if we have a deficiency in those, we may see an increased activity. But for the most part, if it is found to be an acute phase reactant, it is clinically insignificant for the most part. So an important thing to remember is factor VIII, again, is an unstable factor. It needs a little help. And so it will circulate complexed with von Willebrand factor. And what von Willebrand factor does is it really aids in stabilizing factor VIII. Factor VIII also functions as a cofactor with factor IX. What we find here is another important role of thrombin in the activation of factor VIII into activated factor VIII. And then proteolytic cleavage of factor VIII dissociates activated factor VIII from the von Willebrand molecule. So remember, we've got factor VIII complexed with von Willebrand factor when it's inactive and in circulation, but once thrombin comes into play, a proteolytic cleavage will dissociate active factor VIII from that von Willebrand factor molecule that it's been complexed with. And that allows for factor VIII, activated factor VIII, to interact with platelet surface phospholipids, specifically platelet factor 3. And then it complexes with activated factor 9 and calcium as a cofactor to convert factor 10 into activated factor 10. So without thrombin, none of this kind of cascade of events could occur. So even though it seems like von Willebrand's is a little bit passive here, it really plays an important role as well. And we'll talk more about it in our primary hemostasis with its role in platelet adhesion. But even before it gets to that point, we have a really important job for von Willebrand factor to help stabilize that factor VIII while it's in circulation prior to becoming activated by thrombin. So factor VIII contains two non-covalently bonded subunits that bind in the 1-to-1 ratio. We have factor VIII with procoagulant activity, and then we have portion that carry the von Willebrand factor activity. So we've got those, this is where we have our bond between those two non-covalent bonded subunits. So von Willebrand is one, and then that procoagulant activity. And then each portion has distinct functions. So each of those binding sites have distinct functions and biologic and immunologic properties. The important thing I forgot to mention about von Willebrand, not only does it stabilize factor VIII, it protects it from inhibition and degradation. Now remember, it is heat labile, so degradation is something that can occur more easily with factor VIII as well as factor V, but in this case we're talking just about factor VIII. And factor VIII is one of the factors that is highly prone to inhibition through inhibitors. So we want to be able to, if we have von Willebrand in that binding site, inhibitors can't come in and take up that binding site and prevent it from becoming activated. Factor VIII deficiency and factor IX deficiency have pretty much exactly the same clinical manifestations. Clinically, it's indistinguishable from factor IX. There are going to be some bleeding tendencies that range from mild to severe. And we'll talk more about those as we go along. The very first thing the physician is going to do in a patient who has a family history of hemophilia is they are going to do COAG testing, or if a patient is demonstrating hemorrhagic tendencies, again, they would do this COAG testing. What we're going to find in a patient who is factor VIII deficient is a prolonged PTT, and again, that's because factor VIII is associated with our intrinsic pathway. We will perform a factor VIII assay, and we will see decreased activity there. Protime, however, will be normal. Fibrinogen levels will be normal. Platelet number and morphology would be normal. Platelet function tests normal, and bleeding time normal. So really the only abnormal tests we're going to see are prolonged PTT and decreased factor VIII assay. Okay, so therapy, replacement therapy for factor VIII deficient patients. If the patient is stable, we are going to try to maintain their factor VIII levels with a concentrate specific for factor VIII called recombinate. The problem with fresh frozen plasma alone is that because of that factor liability, it may not be sufficient for replacement in factor VIII deficient patients. Now remember, factor V and factor VIII are going to be a little bit decreased in that fresh frozen plasma. And part of that is because when we have fresh frozen plasma, we have to warm it, thaw it, and that heat that it's exposed to can cause a degradation in some of those factors. Not all, but some. And we are going to try to maintain that factor VIII level of equal to or greater than 30% activity. Some patients are on regular doses of factor VIII, while others receive standard doses at the first suggestion of bleeding. So depending on the patient's severity or how deficient they are, they may come in weekly or every 2 weeks for factor treatment with that recombinate, and others might not ever have treatment unless there are instances of bleeding, and then they go in, they get a transfusion of this recombinant therapy, and then they are fine. Now, we haven't always had replacement therapy, and in the past, patients who were hemophiliacs or who had hemophilia were treated through blood transfusion. So some of these therapies that we have now are just such an improvement from the past. If a patient with a factor VIII deficiency needs to have surgery, it is possible to maintain adequate factor VIII levels. It's just important to know and keep a monitor the factor VIII levels to make sure that they don't have an increased risk of bleeding. So maintaining that an increased factor level would be probably the best course of action prior to surgery. Again, if a factor VIII inhibitor is present, we can treat it with that Novo-7 that we use for replacement therapy in factor VII deficiencies to bypass that intrinsic pathway and therefore not cause the inhibitor to increase. Because remember, if we give recombinate and there is an immunologic inhibitor or an antibody formed against that recombinate, if we continue to give recombinate, more and more of those inhibitors are going to come in. They're going to inhibit the factor VIII that is functioning. Even if it's decreased, we want to maintain as much of our functional activity as we can. Because again, remember, a lot of times we don't have to have our full activity to maintain normal hemostasis under normal circumstances. So we don't want the factor VIII to become even more inhibited. Factor IX deficiency. So a few things about factor IX. You may have heard it called plasma thromboplastin component, or PTC. You may have heard it called hemophilia B or Christmas disease. All of those names are associated with factor IX. Factor IX is also vitamin K dependent, and it's a single chain glycoprotein that again is synthesized in the liver. The deficiencies associated with factor IX are typically sex-linked recessive in inheritance, and factor IX functions as a serine protease. Again, I mentioned this when we were talking about our factor VIII deficiencies, but the clinical manifestations of factor IX deficiency are clinically indistinguishable from factor VIII. So they have the same type of clinical manifestations. And interesting thing, a child who is found to be deficient in factor IX, prepubescent child, may actually see an increase in levels, quite modest increase after puberty. So that's interesting. We don't see that so much in factor VIII, but we do see that in factor IX. Okay. So factor IX is, again, one of our intrinsic factors in the intrinsic pathway. It is activated by, in a couple different ways, actually. So first, it is activated by activated factor 11 in the presence of calcium ions. And then we have an extrinsic association here as well with that factor 7 tissue factor. It helps to activate factor IX as well. So factor IX and active factor IX bind to activated platelets, but it does not bind to inactive platelets. So we have to have that platelet activation before factor IX can bind to them. Active factor IX is inhibited by antithrombin, which is one of our naturally occurring anticoagulants, and it forms a one-to-one stoichiometric complex. So antithrombin inhibits, it binds to activated factor IX to prevent it from catalyzing further coagulation. Factor IX deficiency is going to look very similar to factor VIII deficiencies in terms of the laboratory results. We will have a prolonged PTT. Remember, it is associated with our intrinsic pathway. Our factor IX assay will be decreased activity. Our PT will be normal, fibrinogen normal, platelet normal, and platelet number and morphology will be normal, and then platelet function tests will also be normal. The bleeding time will be normal as well. So the only thing that really helps us differentiate the difference between factor IX deficiency and factor VIII deficiency is going to be this factor assay test. If a patient is found to be deficient in factor IX, we can treat with a very specific concentrate called Benefix, which is a factor IX concentrate. I always tell students one easy way to remember the difference between the factor treatments or the factor concentrates for factor VIII and factor IX is recombinate, ends with the 8, ends with the sound 8, which is a factor VIII replacement. And Benefix ends in IX, which is the same as the Roman numerals for factor IX. So if you have difficulty memorizing those treatment therapies or those replacement therapy names and the factors that they go with, those are at least two easy ways to remember factors 8 and 9. Fresh frozen plasma alone is insufficient, and it's not so much that it's not present, it's just that most patients with a factor IX deficiency are so deficient that the amount of factor IX in fresh frozen plasma is not sufficient to replace. And that Benefix has a higher concentration of factor IX, excuse me. Again, it's possible to maintain adequate factor IX levels for surgery, and if factor IX inhibitors is present, we can treat this as well with Novo7 to bypass that intrinsic pathway. And so the factor VIII and factor IX are the most common specific factor inhibitors, and usually it's because of an inhibition that occurs due to the immunologic response against the treatment, so these concentrates that are given. But we would treat it in the same way that we treat a factor VIII inhibitor. Our hemophilia patients are typically divided into 3 groups, and again, that is going to include both factor VIII and factor IX deficient patients. Our first category is classified as severe, and these patients are going to be found to have 0 to 1% factor activity for either 8 or 9. They are going to be at risk for repeated spontaneous bleeding, prolonged bleeding after surgery. They may commonly develop large hematomas and hemoarthrosis, so again, that bleeding into the joints. And they could also suffer from intracranial bleeding, so brain bleed. The second classification or category is moderate. We will see a 1 to 5% activity in these patients. Bleeding from the mouth and nose, which could be associated with injury or trauma. Spontaneous hematuria, so spontaneous blood in the urine, could occur. Prolonged and severe hemorrhage following tooth extractions and or surgical procedures, and bleeding at circumcision. Now, if you think about it, a lot of babies who are circumcised, this is at really the first point in their life when there may be a suspected deficiency. But it's really difficult to determine if a baby is deficient at birth simply because the baby's liver is so immature that a lot of those vitamin K dependent factors are not going to be present, and this is why we give vitamin K injections to babies at the point of at birth, because we want to stimulate the production of those coagulation factors that are vitamin K dependent. So while bleeding at circumcision is not uncommon, what we want to be looking for is excessive bleeding, because excessive bleeding would be an indicator that maybe there is a deficiency that's not associated with just having an immature liver. The third category would be mild. So these patients would have a milder propensity for bleeding, and we would see about 60 to 30% factor activity. There may be no spontaneous hemorrhage, but there could be excessive bleeding after tooth extraction, because obviously the spontaneous hemorrhage would be more associated with a lower percentage of activity, but trauma or surgery could initiate a bigger problem for these patients. Tonsillectomy is especially dangerous for this group of patients because sometimes there is no history, or they don't know that they have a factor deficiency until they have tonsils removed, and sometimes tonsillectomy is one of the few surgeries that children have early in life. Factor VIII levels are usually lower in blood group O than in other groups, fun fact. And so corresponding to the level of von Willebrand's as well. So von Willebrand factor is also lower in type O blood groups. And if you remember, von Willebrand factor has a really important role in stabilizing that factor VIII. So we really have to take the blood type into consideration when diagnosing a factor VIII deficiency, because blood type O groups typically have a lower level anyway. Factor X, also known as Stewart-Prower factor, is a glycoprotein, again synthesized in the liver. It's also a vitamin K dependent factor, and we don't see factor X deficiencies often. They are extremely rare. It's an autosomal recessive inheritance pattern. What we find is pretty much like a 50-50 with heterozygotes. They have about 50% normal level, and of course, remember, we don't always have to have 100% activity to have normal hemostasis. So 50% these patients would probably not have clinically significant manifestations unless there was a large injury or surgery. And then homozygotes typically have very, very low levels, so they would be at a more increased level of or more increased risk of hemorrhage. Factor X is also associated with amyloidosis. So what we see in amyloidosis is we see starch-like deposits in various tissues, And then as factor 8 is circulating, it will come across these amyloid fibrils or these amyloid deposits and bind to them. Factor 10 is a calcium binding protein that interacts with membrane surfaces. Inactivated factor 10 is inhibited by antithrombin and alpha 2 macroglobulin. So remember I said that early on in these lectures that inhibitors could be good and bad. Now when we see things like inhibition of factor activity due to factor inhibitors, that's not good. But in the case of antithrombin and alpha 2 macroglobulin inhibiting factor, activated factor 10, this is a beneficial inhibition because it is aiding in maintaining the balance between coagulation and anticoagulation. And again, antithrombin is a natural anticoagulant in our blood, and as is alpha 2 macroglobulin. So this type of inhibition is beneficial to us in maintaining that hemostatic balance. Factor 10 deficiencies can have some clinical manifestations that look a little bit different, and it really depends upon the level of factor 10 that's present. It could include easy bruising, mucosal membrane bleeding, menorrhagia, epistaxis, ecchymosis, hematomas. And one of the first things that we notice in newborns with a factor 10 deficiency is that umbilical stump bleeding. In patients who have a homozygotic pattern of inheritance, they may have severe bleeding. And a patient who usually doesn't have spontaneous bleeding may have bleeding with trauma or surgery. Laboratory results with patients for patients with factor 10 deficiencies may look like this. There may be a PT prolongation and a PTT prolongation. Now, if you think about it, the factor 10 is right at the very beginning of the common pathway. However, there are some variants that have been identified in only one pathway, either the PTT or the PT is prolonged. So there are variants, but for the most part, what we would expect to find are prolonged PT and PTT. Now, if you think about the point of activation for factor 10, we do have some thrombin activity there, but we also have active factor 7 that merges down into that common pathway from the extrinsic pathway. And remember, when we do that stipend time with that Russell's viper venom, factor 7 does not play a role in that. It's not affected by that. And so we have a normal stipend time for factor 7. But we have a prolonged stipend time with factor 10 deficiency because factor 10 is associated with that reaction or that interaction. And that's because sometimes factor 10 and factor 7 deficiencies are a little bit tricky to identify one from another simply because of the point of convergence of that extrinsic pathway into the common pathway. A factor 10 assay would also be decreased. So that specific factor assay would be decreased, which would really point us in the right direction. And an important note for therapy with regard to factor 10 deficiency, it is vitamin K dependent. However, it does not respond to vitamin K therapy. So vitamin K is not going to be helpful with regard to treatment for factor 10 deficiency unless the cause of the deficiency is acquired due to vitamin K deficiency. And then you would have a deficiency in all of your vitamin K dependent factors. But for a true deficiency, it does not respond to vitamin K therapy. Best course of treatment would be a prothrombin complex concentrate or fresh frozen plasma. And the good news is hemostasis requires only about 10% of normal levels. So hopefully those heterozygous patients with about 50% are okay. Factor 11, also known as Rosenthal's factor, PTA, or hemophilia C, is the fourth most common inherited bleeding disorder. Has an estimated frequency in the general population of about 1 out of every 1 million. That comma is in the wrong place. My apologies for the typo. The highest frequency is seen in Russian Ashkenazi Jewish populations, with about 0.2% being homozygous for factor 11 deficiency and 11% heterozygous. It is again an autosomal recessive inheritance pattern, and this glycoprotein is synthesized in the liver, and it's a part of our contact factor group, or our contact group. So there's an interesting little tidbit about factor 11 deficiencies and their clinical manifestations. The interesting thing is the severity of the disease or the severity of the manifestation of symptoms does not correlate well with the levels of factor 11 activity, which is different from the other factors. So normally we see with a decreased factor activity, we have more severe symptoms or clinical manifestations. And in the case of factor 11, that just isn't true. What we do typically see is mild bruising, epistaxis, and menorrhagia. Laboratory results for factor 11 deficiency like um, will look like this. We will have a normal PT and a prolonged PTT. Again, that's because our factor 11 falls within our intrinsic pathway. Therefore, that PTT is prolonged. Our factor 11 assay will be decreased. We will have a normal bleeding time. And remember, because this is a contact factor, we really want to draw it in a plastic tube to avoid activating the factor. Because remember, glass tubes have a negative charge, and that will activate that coagulation through that negative charge. If there's a true deficiency, we're going to see decreased antigenic levels, indicative of a decreased population of the protein. So true deficiency is really that we aren't producing enough. So therapy for factor 11 deficiency is going to be very similar to what we have seen for other factor deficiencies. However, there really isn't a specific concentrate for factor 11. We would use fresh frozen plasma in patients scheduled for surgery just to kind of boost their coagulation factors. Hemostasis typically only requires 15 to 20% of the normal levels, but again, remember, it doesn't necessarily correlate with the factor activity levels and the severity. So there are a lot of things that have to be taken into consideration with regard to the patient's history. And again, factor 11 inhibitors are pretty rare. Next on the list is factor 12, or the Hageman factor. This is also a contact factor. It's right up there with factor 11. And we have both quantitative and qualitative forms of deficiency that exist, or you could say both absent and dysfunctional forms. So there are a couple of interesting facts about factor 12 deficiencies and the clinical manifestations associated with that. Typically, we don't see an association with hemorrhagic manifestations unless we have a very, very elevated or prolonged PTT of greater than 100. That would really be indicative of an extreme deficiency. But patients may present with thromboembolic complications rather than bleeding complications. And the reason for that is that factor 12 is a contact factor, and contact factors are notorious for stimulating coagulation kind of by accident or unnecessarily. Factor 12 deficiency laboratory results are as follows. We again have a normal PT, but a prolonged PTT. And that's because prolongation of the PTT is going to be associated with that intrinsic coagulation pathway. Factor 12 assay will also be decreased. So always keep in mind, and I know I've mentioned this over and over again, but I like to repeat myself so that it really sticks. When we are doing coagulation screening, specifically our PT and PTT, that's going to be the first testing we do, and we're going to evaluate prolongation in either the PT, PTT, or both. That's going to kind of give us a hint about where our deficiency or our problem in coagulation may lie. Again, that PT is going to be prolonged if we have a problem in the extrinsic pathway. The PTT will be prolonged if we have a problem in the intrinsic pathway, and both the PT and the PTT will be prolonged if it is a common pathway factor that is deficient. So keep all of those things in mind. Now, it's easy to say, oh, well, look, this factor assay is decreased, so we know it's factor 12 deficiency. Yes, in this case, but physicians don't always go straight to factor assay. There are so many factors they would have to test for. So usually they like to kind of get an idea of where to start, and that's why PT and PTT are so helpful in helping kind of point us in the right direction so that we can do further testing. Because factor 12 deficiency is not typically associated with hemorrhagic tendencies, replacement therapy isn't very often needed. But in the case where they have an extremely elevated PTT and are at an increased risk for hemorrhage, we could use that FFP when necessary. Factor 13 is associated with our endpoint in hemostasis, and it is also known as the fibrin stabilizing factor. Deficiencies in factor 13 are extremely rare, with a prevalence of only about 1 out of every 5,000 people, and very much like factor 8, it can be an acute phase reactant. So we may see an elevated factor 13 activity in things like pregnancy, inflammation, chronic disease, maybe even hormone therapy, any of those things that could cause a reactivity. Most deficiencies are obtained or inherited through autosomal recessive inheritance patterns, and usually this occurs in communities with a high incidence of consanguinity, where essentially closely related relatives marry each other and have offspring, and those offspring are at a higher risk for inheriting these factor 13 deficiencies. Homozygotic patients have undetectable factor 13 levels, and we also have a few cases that could cause an acquired defect or deficiency. So certain types of leukemia, liver disease, metastatic carcinomas, pernicious anemia, myeloma, lead poisoning, collagen disorders, gamma globulinemia, and recurrent spontaneous abortions. All those things are associated with acquired factor 13 deficiencies. Now, I hope you guys are taking note, because you know how I like to throw in our past into our present, pernicious anemia. Remember, that is going to be one of our macrocytic megaloblastic anemias, and that could be associated with our B12 deficiency, or rather our B12, our inability to utilize B12 due to lack of intrinsic factor. So don't forget what we've learned in our red blood cell unit. Multiple myeloma is going to be associated with that M spike in the gamma region of our protein electrophoresis. Remember, lead poisoning, and so on and so forth. So please, please, please start putting the pieces together on how the things that we've learned in the past can be associated with other things moving forward. So beautiful thing about our body is that it works together in harmony until there's a disorder or something interrupts that harmony, and we can start to see overlap in all of our areas of study with our chemistry, biochemistry, molecular, genetics, hematology, et cetera, et cetera. So this is where we start seeing the bigger picture about how some of those disorders we learned about earlier can affect our well-being in multiple ways. Speaking of biochemistry, let's talk about some of the biochemical aspects of factor 13. Factor 13 is found both in the plasma and platelets. The platelet associated factor 13 is activated by thrombin, and again, here we are, thrombin is playing a role in activation of platelets and factor 13, and it acts much sooner than does that plasma factor 13. And because plasma factor 13 has to be activated through a process that requires calcium as a cofactor, and so it just takes a little longer. Plus, usually platelets are right there at the site of injury or bleeding, and it's at that point where they become activated initially. So transglutaminase is present in that calcium ions, produces covalent bonds between the fibrin molecules. So if you think about, remember our platelet plug formation that we briefly spoke about, what happens is our platelets will form a plug, and then these strands of fibrin will form a mesh to kind of help hold it into place. And then we have factor 13 that comes in and produces those covalent bonds, which really kind of helps stabilize it. That's why we call it the fibrin stabilization factor or stabilizing factor. Factor 13 deficiency clinical manifestations is, it kind of varies. And that's really because it depends on the pattern of inheritance, the deficiency, but it can be problematic for a lot of patients who are truly deficient. Umbilical stump cord bleeding is common, so we might have weeping or bleeding around that baby's umbilical stump. Delayed post-traumatic bleeding, so maybe a patient has a small injury and then you clot, but then it starts bleeding again over and over again, and that's because that platelet plug is only temporary until it is acted upon by factor 13, where it becomes more stable and insoluble. And then poor wound healing following surgery or trauma. Interestingly enough, factor 13 has the most common cause of death for factor 13 deficient patients is intracranial hemorrhage. That's wild. I would not like to be a patient who is factor 13 deficient. The problem with factor 13 deficiencies is they can be a little bit tricky to diagnose, and that is because all of our routine clotting tests are normal. Now, if you recall, factor 13, it kind of goes off and does its own little thing at the end of the COAG cascade where we have endpoint hemostasis and clot fibrin stabilization. We can't measure factor 13 activity with the PT or the PTT. Even though it falls toward the end of the common pathway, it's really not actually a part of the common pathway. It's the kind of the cap that holds it all together. One of the first clues that we can determine is that there may be a defect in the clot, and that is where you have a blood clot and it has kind of like it's called friable edges. So it's going to look kind of ratty, like a ripped or tattered piece of fabric around the edge. Factor 13, if it's absent, the clot will be soluble in a 5 molar urea concentration or 1% monochloroacetic acid. 1 to 2% of factor 13 activity is sufficient for normal clot stabilization. And actually, it's unless you have a complete absence of factor 13, you probably won't be symptomatic unless there's a large trauma or a surgery or something. We can also use other assays that are available which measure enzymatic activity or other immunologic techniques, but in terms of a screening test, the solubility test in 5 molar urea is the one we use here at St. Luke's. And we like to kindly refer to them as our PET clots. Always exciting for students when we do that in our laboratory, our student laboratory, so that they can come back the next day and see whether or not their PET clot survived the night or not. And I'm happy to say that this term, all of our clots survived. Because hemostasis can be achieved with very low levels of around 0.5%, Bleeding isn't usually a big problem for factor 13 deficient patients unless they are completely devoid of all factor 13, where then again you would see an increased risk of maybe intracranial hemorrhage, etc. But if we did need to treat a patient for factor 13 deficiency, frozen plasma or cryoprecipitate would be the factors of or the replacement therapies of choice. Let's talk for a few minutes about high molecular weight kininogen, or as I like to refer to it, homework. Or you could call it Fitzgerald factor if you wanted to. All of those things would be correct. Again, this is a contact activation factor, and deficiency is fairly rare. If there were to be a deficiency found, it would be through an inheritance of autosomal recessive pattern. And deficient patients are usually not symptomatic, so they're usually asymptomatic, but again, they may display thrombotic tendencies. So remember, those contact activation factors can sometimes accidentally activate coagulation. What we would find would be a normal PT and a prolonged PTT. And remember, that's because the PTT is measuring our intrinsic factor and our homework, or our high molecular weight kininogen, is associated with our intrinsic pathway. Prekallikrein, or Fletcher factor. So this one's a little bit different in terms of its inheritance patterns. True deficiencies are rare, but they can be found via autosomal dominant or recessive. Acquired defects can also be seen in liver disease, uremia, and in newborns. And again, remember, our newborns typically are pretty deficient in all of their COAG factors. Now, prekallikrein is activated by active factor 12 in the presence of homework, so homework has to really play its role. So if any of those factors are devoid or deficient, normal coagulation cannot occur. Kallikrein then continues the activation of the intrinsic pathway and directly activates plasminogen to become plasmin. So this is going to be a very important factor because once prekallikrein is activated into kallikrein, and due to it being a contact factor, it can actually activate plasminogen to become plasmin, where now we're going to activate our fibrinolytic system. Now, we haven't gone into detail much about fibrinolysis, but just know that plasminogen being converted into plasmin allows for clot breakdown. So this is going to trigger not only the intrinsic pathway to facilitate clotting, but it's also going to activate the fibrinolytic system, which is going to promote clot breakdown and also regulation of the coagulation cascade. Deficiencies fail to properly activate the fibrinolytic system, and that is why thrombotic tendencies may become evident. So in this case, not only is it a contact factor, but if you have a deficiency and you can't activate that fibrinolytic system, which acts as a not only clot breakdown, but as a regulator of the coagulation cascade, we might have out of control clotting that occurs because of lack of regulation in the coag cascade, but also there would be a non-activation of plasminogen to plasmin, so clot breakdown could not occur at the proper rate. What would a prekallikrein deficiency look like with regard to laboratory results? Well, first of all, we would have a normal PT, and we would expect to see a prolonged PTT because we know that prekallikrein is in fact associated with our intrinsic pathway. Interesting thing though is that our PTT may become more normal with extended incubation times. And that's just because if we incubate, the prekallikrein that is available, even if it's deficient, has longer time to activate various components that it's responsible for activating. Bleeding time might be completely normal, and then our prekallikrein assay would be decreased. There are a couple of combined factor deficiencies that we typically find together. So factor 5 and factor 8, again, both of those are heat labile factors. We most commonly see them, they are the most commonly combined deficiency. Both antigenically and functional levels are decreased. And when we have factor 5 and factor 8 deficiency, Usually we have bleeding that is mild to moderate depending on how deficient the patient is. So again, we've been talking about vitamin K dependent factors, but let's revisit this for a moment. Let's remember our factors that are vitamin K dependent are going to be factors 2, 7, 9, and 10. They are all synthesized in the liver and require vitamin K for that synthesis. And of course, vitamin K is going to be found in leafy green vegetables, and it is synthesized in the GI tract by our normal flora. So the bacteria in our GI tract actually breaks down the components of those leafy green vegetables and produces vitamin K. So the deficiency of the vitamin K can occur because of poor nutrition. So it might just be that we aren't eating enough of those sources that could be rich in vitamin K. It could be problems with the liver and or GI tract. So is vitamin K not being produced because our GI tract doesn't have the right flora, or is the liver not working so it can't synthesize those factors? And maybe even some use of Coumadin type anticoagulant drugs, which inhibit that carboxylation of the factors um, that are vitamin K dependent. Newborns are usually deficient in all factors because of liver immaturity, like I mentioned before, and a lack of normal gut flora. So again, both things are required to make those vitamin K dependent factors. And then we also have some drugs. Now, sometimes we want drugs that affect vitamin K because that can help us as an anticoagulant therapy. So let's talk about warfarin or Coumadin. Um, Coumadin inhibits the carboxylation of the factor, which prevents it from binding to calcium and platelet phospholipids. It takes about 1 day to 2 days to produce a noticeable prolongation in the PTT, and factor 7 is the first to decrease. Now, I will tell you that factor 7 is the first factor to decrease, but we have other components that are also a part of our fibrinolytic system that regulate hemostasis. And some of those components, which we will talk about when we get to our fibrinolysis unit, they actually decrease prior to factor 7, but we'll talk more about those later. They're not really pertinent to this exact moment. So factor 7 is the first to decrease with Coumadin therapy, followed by 9, 10, and then 2. Factor levels return to normal when the drug is discontinued, typically in 3 to 5 days, but administration of vitamin K can shorten this recovery period. So the important thing to know is that with Coumadin therapy, if someone accidentally takes too much or they've taken too high of a dose and they need to change that, vitamin K shots can be given to kind of mitigate the risk of bleeding. Antibiotics can affect vitamin K dependent factors, and this is because they cause a reduction in the normal flora in the GI tract, causing a vitamin K deficiency. So circulating anticoagulants, I had talked a little bit about inhibitors. Some of them are helpful, some of them not so much. And we're going to talk kind of about the ones that are not so much. So first and foremost, we have specific inhibitors, which are directed against a single factor. And the most common that we've talked about are factor 8 and 9 inhibitors. They could be IgG or IgM antibodies that inhibit coagulation activity. And factor 8 inhibitors are enhanced by prolonged incubations at 37 degrees. So the longer we incubate, the more inhibition can occur. Non-specific inhibitors aren't directed against a single factor, but rather multiple factors. The most common type of a non-specific non-specific inhibitor is lupus anticoagulant or antiphospholipid antibody. We can perform lab testing, and when we do lab testing, when there is a non-specific inhibitor, a lot of times it suggests a bleeding problem with regard to what our testing results look like, but most patients actually have a thrombotic problem. And the reason for that is because of the interaction with the phospholipid reagents that we use. So it'll prolong the PTT, for example, but really it's a clotting problem. It's a problem with excess clotting rather than bleeding. We've talked about several testing methods that we utilize to determine factor deficiencies. So we want to talk a little bit more in depth about factor assays and inhibitors. So when we perform factor assays, we perform them with at least 3 dilutions. And the reason we do this is we want to rule out a non-specific inhibitor. This is a CAP requirement, but it's also highly beneficial for us so that we can actually see what's happening as we dilute out a sample. So what we tend to find with non-specific inhibitors is an increase in factor activity as the dilutions increase. And here's an example. We have a 1 to 10, which is demonstrating 5% of factor activity. A 1 to 20 is going to be 39%. 1 to 40 is 94%, and 1 to 80 is 128%. Now, in a normal factor assay, what we should see, regardless of dilution, is our results should be within about 20% of each other max. So they should all be very similar or within, kind of a similar range. So here we see a lower activity at a lower dilution and then an increased activity at a higher dilution. And the reason for that is as these dilutions increase, the inhibitor is actually getting diluted out and allowing the factor to become uninhibited and therefore increase the activity. And so that's why we're seeing an increased activity. Now, remember, non-specific inhibitors affect more than one factor. And so the results that we see with a non-specific inhibitor are going to be different than what we see with a specific inhibitor. So for a specific factor inhibitor, like a factor inhibitor for 8 or 9, it will cause the results to simply appear as a normal factor deficiency. So a 1 to 3 is 9%, a 1 to 10 is 11%, and a 1 to 20 is 10%. Now you can see that all of these results, even though they are increasing in dilution, are all within 20% of each other. They're all similar in terms of the range. And that's because this is a specific inhibitor that isn't so much being diluted out because it's bound specifically to factor 8 or factor 9 or whatever factor that it's inhibiting. It doesn't just dilute out the way a non-specific inhibitor would. Now, how do we know if this patient is truly deficient or if this is a factor inhibitor? First of all, we would look at the patient's history. Do they have a history of deficiency? Have they been known to receive therapy replacement or replacement therapy in the form of like a recombinant or a Benefix? And if so, what are their clinical indications? So if we do suspect a specific factor inhibitor, we would do a factor 8 or a factor 9 or whatever factor inhibition testing and get kind of a better idea of what we're looking at. Obviously, if this patient has had a history of, say, factor 8 deficiency or hemophilia A, and they've been receiving their recombinant concentration and we're still seeing low activities, it may be that another sign that they have an acquired specific factor 8 inhibitor. And that would be induced due to the administration of recombinant therapy. And usually that's what we see. Usually these patients have a history of hemophilia, whether it's A or B, depending on the factor deficiency that they have. And what will happen is we have to test them and before they get their recombinant or after they get their recombinant. And if we aren't seeing an increased level of activity, even though they've been given the replacement therapy, chances are pretty good that they've developed an inhibitor against that factor. So again, if this were a factor inhibitor of, say, like factor 8 or factor 9, and we wanted to decrease the propagation of that inhibitor, we could bypass this point in the intrinsic pathway by giving the patient Novo-7 and kind of rerouting or detouring that process instead of giving them that Benefix or that recombinate that is stimulating the production of those inhibitors.